All right, thank you, Oyeyemi Ajayi, for the background report. We have right here in the studio Dr. Francis Onhanyudo, and he's Director General, West African Institute for Public Health. We'd like to thank you very much for coming.
Thank you very much. It's a pleasure to be here.
All right, also joining us for the conversation, but via Zoom from Azare, is Professor Bala Mohammed Audu, the President, Nigerian Medical Association, NMA. He's also the Vice Chancellor of Federal University of Health Sciences, Azare, Bauchi State. Many thanks for joining us, Prof.
Thank you for having me, viewers.
See on your screen. So we also have joining us via Zoom from Abakaliki, Michael Nachi, the President, National Association of Nigerian Nurses and Midwives. Many thanks for joining us, Michael Nachi. All right, and also via Zoom, and but from outside the country, from Canada, actually, we have Dr. Itwa Godson Iriogwe, the President, Canadian Association of Nigerian Physicians and Dentists. Many thanks for joining us, Dr. Iriogwe.
Good morning, viewers. Thank you for having me here today.
All right, thank you, gentlemen, for joining us. It's an all-male affair in terms of our guests, but it's also an all-female presentation affair, so it's equation balanced. Again, we are back to discussing how we can bridge the gap in healthcare delivery in the country. And this probably, I would say, is prompted by, again, the alarming statistics coming from NMA in terms of widening gap in doctor-patient ratio. And I'm wondering, maybe I should also start with the president of the NMA Association, Professor Bala Mohammed Audu, who is joining us from Azare. Can you give us more insight into these, disheartening, if you may, statistics?
Thank you very much. Let me start by saying that we need to focus on what exactly achieved in the Nigerian health sector. There are two fundamental issues: to deliver quality, patient-centered, respectable care, both in the public and the private sectors, on the one hand, and second, to ensure access to this quality patient care by all Nigerians, what is basically referred to as universal health coverage. Among other things, the cornerstone of achieving that involves both the workplace environment in terms of infrastructure, diagnostic, what is available for prevention, investigation, and for treatment. But very importantly, the manpower for health, ranging from doctors, nurses, other healthcare providers, including community health extension workers, pharmacy technicians, and so on and so forth, at the primary care level through to secondary and tertiary care level. What we have seen in recent years is a mass migration of doctors, nurses, and indeed many healthcare providers out of this country to more lucrative developed countries in the West, as well as the Gulf states. These are mainly push factors that make them leave this country greener pastures. These push factors center around the workplace environment itself, as well as the conditions of services that ensure the well-being of these care providers. Unfortunately, the whole world will see a deficit in healthcare providers to the tune of about, I think, by 2030, which means what's going to happen is that countries that can offer the best conditions of service in terms of both workplace environment as well as the well-being will compete at a very great advantage against low middle income countries like Nigeria. This would result in a dwindling population of healthcare providers, and in a country like Nigeria, versus an increasing population, further worsen the doctor-patient ratio, which is 1 to 600, as recommended by the World Health Organization, but currently stands at about 1 to 5,000. And this would most likely be in our urban centers that have more proportion of doctors. This is more likely to be a lot more in our rural areas, where there is an uneven and inequitable distribution of both health facilities as well as manpower. The exact figures of these numbers is very dynamic, but suffice to say that a large proportion of people, including Nigerians, who move out of their countries for medical reasons in developed Western countries such as the United Kingdom and the United States, and end up a lot of the time Nigerian doctors who were trained in this country, who could provide and provided these best quality services to our citizens, but who have been taken up by other countries to provide services to their own citizens.
All right, thank you very much, Professor Audu. We'll definitely get back to you in the course of this conversation, but we have to get to Dr. Iriokwe now, because you have mentioned the mass exodus of medical personnel out of this country has been responsible for what we see in the health sector, and of course putting the ratio at what you have said. So I'd like to find out from Dr. Iriokwe, who practices outside Nigeria and a medical practitioner. We want to know, what are the push factors, or what is responsible for medical personnel seeking greener pastures outside Nigeria? Just talk to us with your interaction with those who get into the country where you are, and maybe also tell us your own experience and why you are practicing elsewhere.
Thank you so much again for having me. I will, speak a bit about what Professor Bala Audu just spoke about in terms of some of the motivating factors that makes people to want to migrate, overseas. And, one of them is lack of facilities, right? So you're a medical doctor, you're trained to provide certain services. And when you want to specialize, you feel that, those facilities are not available. Sometimes you don't have enough openings, for you to do training also. You also don't have enough manpower around you to support you if you decide to actually go into, working in Nigeria. In addition, let's not, run away from it. Money is quite important. You have to look after yourself, look after your children, look after your extended family also. And if you feel that, you know, at the end of the month, the amount of money you make is not sufficient for you to survive and to take care of your immediate family, then you start thinking about going overseas, whether within Africa or outside Africa, to seek for greener pastures, as we say. And most of the folk coming to Canada, I think they fall within that particular category. People are also really determined to learn, to expand their skills. They want to be in an environment where they have access to, you know, first world facilities, first world experts, as well as the ability for them to navigate a system that doesn't have a lot of roadblocks or bottlenecks for them. My personal experience is I left Nigeria a long time ago. I first went to South Africa, where I went and I specialized in family medicine there. And that was a very good training ground for me for a while. And afterwards, I moved to Canada, which, you know, that's where I am currently. And I'll tell you that the difference is really quite remarkable between the practice, what you have in South Africa or in Canada compared to what you have in Nigeria. The independence you have, the facilities, the support system, the government provides that support for you here for you to succeed. I mean, we also have some concerns in the healthcare sector here in Canada that we wish that the government will really improve on. But when you compare them, right, you know, Canada is really, you know, on a different plane compared to Nigeria. And I believe that it's not the end of everything. I know that probably you talk about this later on, but I believe that there are mechanisms in place to sort of repatriate some of these skills back to Nigeria to help the healthcare sector, to boost it, and to ensure that our colleagues working in Nigeria, they get the support that they need from those of us that left the country, you know, many years ago. And a lot of us do come back to Nigeria to work in various hospitals. Some have set up a lot of very, very world-class facilities, you know, in Nigeria, particularly in Lagos, I must say, and they are doing very well. And we have a number of them who are willing to actually come back to Nigeria to bring back those skill sets, you know, that they've learned here in overseas. If we're talking about repartition of skills, I was fortunate to be in a meeting where the Minister of State for Health, Dr. Tunja Alausa, did a presentation in America recently, and he had some government officials with him also. And I must say that the government has a robust plan to actually improve the healthcare sector in Nigeria. And they are looking at the diaspora, doctors, healthcare workers, nurses, pharmacists, to be part of that plan. And when you have people who actually work overseas, they're now working in Nigeria. These are technocrats, people who know what it takes to deliver a good healthcare service. Then you want to look at what the plan is and how you can actually, you know, support them. Yeah, I'll just stop for now. Thank you.
Thank you. And I should indeed say a very big thank you to you, because you had to join us in the wee hours from Canada. I don't know what time it is, somewhere around maybe 3 a.m. or thereabouts in Canada from where you are joining us. Thank you. You've enumerated some factors, push factors, learning, expanding skills, you know, use of facilities, navigating a seamless system, which is what is going for those who have jackpot. But I would also say that some of these, themes are also, available here. If we talk about maybe facilities or even the system, a bottled system, maybe we could say, yes, these are issues that we could address. But thank you. Let me just put you on hold, Dr. Itwa, and get back to someone who has been wearing the shoes. And as we say in our local parlance, he who wears the shoe knows where it pinches. And that's Michael Nnachi. Michael Nnachi is President, National Association of Nigerian Nurses and Midwives. Like I said, Mr. Nnachi, you wear the shoe, so you know where it pinches most. How did we get to this stage where we are having 10,000 patients to one doctor?
Thank you so much for this very important opportunity. I think it's a critical one. Yes, when you look at the health sector and the attainment of universal health coverage and sustainable development goals, it becomes a critical situation in the health sector. The nurses, Nigerian nurses and midwives actually are the epicenter of these activities where it results. And the essence of healthcare is to provide qualitative healthcare that is safe and then accessible to the beneficiaries or the healthcare seekers. Now let us look at the Nigeria population, which is over 220 million. We analytically look at how many nurses are employed. Few are employed. And as a result of the number that are employed, many are roaming about, but those that are employed are overutilized in such a manner that in a particular unit, you may have few nurses that are employed, but they have high workload that even when we ask the government to employ, it is rather politicized instead of employing more hands. And we know that we cannot achieve universal health coverage and sustainable development without having adequate number of nurses and midwives. To what extent are the nurses being taken care of? That has been an issue. There is no way you can talk about brain drain without talking about the push factors and the pull factors. Our other colleagues, the medical doctors, have made it clear that there are push factors and pull factors. Now, centering on conditions of service of the healthcare workers, all inclusive, the nurses are entirely at the disadvantaged time. Because if you look at the population of Nigeria at 220 million, you now look at the ratio of patient-nurse ratio as provided by World Health Organization. That has become a total mirage. Talk less about the critical situation whereby you need to have at least one nurse to 4 patients. But all these things are mirage. So basically, we look at the conditions of service. Up till now, the government is just to address the issue of conditions of service of nurses. Looking at employment rate. So the policies that characterize the health sector actually need to be addressed. Not that I'm not speaking on one side, the government in themselves are doing so well to equip the health sector. But such equipments are underutilized and then maintenance is poor. Equipment can be available, but to maintain it becomes another issue. Equipment can be available, to utilize it becomes another issue. So basically, it is important that a good environment needs to be established. And this good environment requires effective teamwork. There is no health sector that can work without teamwork. The medical doctors are critical. The nurses are critical. The pharmacists are critical. The medical lab scientists are critical. And we need to work as a team. Without teamwork, we can achieve a little. And looking at the health sector, every person is in a critical position to need the help. It could be anybody, the nurse, the doctor, a relation. Now, if we are not working together, what are we likely to achieve? Nothing. The system will suffer. And for us to work as a team, we need to objectively look at issues that concern each professional group without dominance or thinking that the other professional group are not relevant. Every professional group is relevant to the health sector, and what aspects need to be addressed. Nobody can clap with one hand. You need the 2 hands to clap for anybody to hear. Therefore, we need to specifically look at teamwork because no one can do it alone. Any health sector without nurses and midwives is entirely a different thing. So when the nurses are forced to pick areas of greater function, it's not as if they cannot work here in Nigeria. It's simply an attempt to survive because after school, you need to be engaged so that you can help yourself, help the family, and help the society. And definitely, we all need to serve Nigeria that produce us. Even when people live outside the country, your parents are in Nigeria. When they are sick, who is going to care for them? Will you be able to take them outside Nigeria like the politicians who can afford it? So most importantly, the conditions of service of nurses and midwives need to be addressed. And then we need to establish holistic teamwork so that we can actually move. Then, of course, a lot of nurses need to be employed because many that are not employed are now taking private jobs that are, honestly, they are not getting anything. And that is why majority that are not employed are leaving Nigeria in search of greener pastures.
Mr. Nachi, thank you. Thank you again, Dr. Ohayido. Now, these are all systemic issues that we are all familiar. But somehow, it's the gaps are still there. What in your factor do you think is exacerbating, these gaps in the healthcare sector?
Okay, thank you. It's a pleasure listening to the speakers, especially my good friend, Professor Audu. I think one of the things, let me start by saying that if you look at the indices of Nigeria, look at maternal mortality rates, it's in the 800 per 100,000 live birth. We, by 2050, will be the fourth largest country in terms of population globally. We have to be worried. And the things that have exacerbated our problems are in the character of our nation. Why I say character of our nation is that some of these things, other countries have been able to manage them, but we've not been able to manage them because a lot of the things that actually affect health lie outside health. Economic issues, political issues. If you don't have good political will within a health system, no amount of input you put in the health system will work. So it's in the character of the nation, and we need to, as a country, begin to shape our character so it can dovetail in every sector of our country. The same things that have dogged us even politically are the same things that are dogging us in the system. So when people talk about health system almost like an isolated space, I worry because it means we're not connecting the dots. The critical issues are around governance issues, and I'll give you clearly. When you look at funding for health, the health sector over the years has suffered in terms of funding, and then within even that funding stream, the burden of diseases is a pyramid, and it's a pyramid like this, right? Your standard pyramid. At the bottom of the social pyramid, you have most of the diseases that afflicts the poor in areas of squalor, where there are no water, we are talking about even cholera epidemic, and all that. So a large chunk of our disease burden, let's say 70-75% are at the bottom of the social pyramid, right? Because a lot of other people who are upper class in sense of access to the things of life, income and all that, can afford to have the services that gives them some level of protection, right? But when you come to invest in the health system, what you see in Nigeria is an inverted pyramid. We tend to put a lot of money in tertiary, secondary level because of procurement issues. I say it's in the character of the nation. Procurement. People want where they make money and all sorts of things. Politicians, everybody, they want to make money. So you put money there and they forget that the primary healthcare system is where the bedrock of the health system is. And Obasanjo should be able to walk out of Ota Farm 10 minutes and get treatment for uncomplicated malaria in a primary healthcare setting of Ota. But we have not gotten there. Why? Character of the nation. Because people are so fixated on making money, enriching themselves at the detriment of the society. And they forget that if an accident happens in Kaduna Abuja road, with all this crazy road there, like we saw with the Minister of State for Labour, who had an accident there. Because the window of response time to get into good healthcare was not there. The man died. So it can happen to anybody. Nigeria can happen to you irrespective of your wealth. So we need to come back to the table and say, look, how do we make sure that health is in our policy, that we see health as the cornerstone of everything we do in the country? Because one thing COVID clearly showed all of us is that even with the high-income countries,
the
health.
way we speak, I'm sorry to interject,
Yes.
the way we speak, it's as if it is doomsday for, healthcare delivery in Nigeria. And I'm just like a former vice president of this country, had cause to seek medical care right here in Nigeria, medical treatment right here in Nigeria, which is an indication that yes, we could have our issues, but we do have facilities, we do have personnel. So why is it that these push factors or these young minds are going out? Is it lack of patience, which again is in our character?
Okay, so I was coming to the positive side. The positive side is that in every setting, you have entropy, what we call entropy in science, where there are factors that play out that you can't even sometimes fathom how they play out. One of the things that's coming clearly is technology. Health technology recently has actually improved some of the opportunities to be able to drive an agenda for health, especially in private sector, because they are tapping into that. The problem with health tech in public sector is that people abuse it, abuse the procurement processes and bring substandard things. It's a way of those things. They tilt in different ways. So for the private sector, they are unlocking the opportunities. So like my brother from Canada mentioned, there are facilities in Lagos that are doing very well. So, but they
private facilities.
Yeah, private facilities, but they are outliers in a system, and it is only for us to be able to learn from that. I'll give you one other problem. For example, we've had PPPs in public partnerships in health system in Nigeria.
Yes, of course.
Nobody has documented.
Gariki Hospital is a
beautiful. Nobody has documented the outcome of those PPPs. We should be learning as a country. One, we don't have information. What has happened? How did they work? What were the good sides? What were the downsides? What have we, as a country, we need to be learning from all those things. We don't. So that's why I say some of those things are in the character of the nation. But there are positive sides, especially with the young people. One of the things my organization does is actually we work with the Africa CDC, what they call the Africa Health Tech Summit, which was in Kigali. One of the things we've been doing across Africa is actually to unlock the opportunities for young people who are tech savvy to be able to see how they can bring a common agenda to health. How can they bring low-tech devices that can improve outcomes for people? These people, a lot of young people have so much talent in Africa in the tech space. So those are some of the things that are, like I said, the positive sides. But before you get the bandwagon to create that critical mass, it's a conversation that the public sector needs to also sit up and be critically part of it. But the good side again for Nigeria in terms of governance, let me tell you up front here, Nigeria has never had, let me say, the right set of people, especially at the national level, to head its health system like you have now. Professor Pate is a friend, I know him very well. Muyi, I know him, I know Kelechi, So these people are astute people in terms of their space. They know it, they know what the issues are, but the structural issues and political dimensions of governance is what will determine how they're able to move.
Talking about how we move
Yes.
in the health sector, some people have also pointed at the budgetary allocation, for the health sector in this country, as against the Abuja declaration of 15%. And what we see, for example, this year, 4.6% of the budget is assigned to health. That's about 1.3 trillion naira. And like you have rightly said, the bulk of that money is going to tertiary health facilities. So how does this, help? Or is this a step in the right direction, looking at what is being budgeted and what is allocated to primary healthcare facilities in the country?
Okay, so the one of the things we did, there's what is known as the National Health Act. And the National Health Act is the only law, the major law for Nigerian health system. And it was developed over a 10-year period with all sorts of challenges, all sorts of fights. And it was finally assented by Jonathan Goodluck in 2014. I think November 4th or so, 2014. The National Health Act, our constitution, 1999 constitution as it was originally, did not speak to health. didn't have up to a sentence on health, which was dangerous for our people as a country with large population like we have. So that law helped to define our health system and helped to define some of the things we needed to do. One of them was a catalytic fund that was embedded within it. It's known as the Basic Healthcare Provision Fund. The BCHF is what Professor Patina is looking to use as the leverage for his sector-wide approaches that he wants to put across, getting donor funding, getting domestic resource towards galvanizing primary healthcare, because we have over 30,000 health facilities in terms of primary healthcare dimension, but we don't have up to probably 25% of them that are functional. So that in itself is a challenge across 774 local governments in Nigeria plus 6 area councils in every state. So we have a challenge as a country. So we need to make sure those structures are the ones working. And one of the things, like I said, the Basic Healthcare Provision Fund that is embedded in the National Health Act is a statutory transfer. The reason is that it's from first line, it's along with like security, so that people don't tamper with it. It goes statutorily for primary healthcare, and it's like a kind of a federal government's this thing, because it's 1% of the consolidated revenue of the federation. Federal government's way of saying, oh, look, primary healthcare is the cornerstone of the health system. We must make it work. But even then, it says not less than 1%. The federal government has not been able to put more than 1%. Education, UBEC, has 2% in that statutory transfer. Why can't we up that for primary healthcare?
But some want to put the blame on the subnationals, not just the federal government alone.
So I'm coming to that. So one of the things that we're also saying is that for you to get more health for the money, for the naira you put in health, we need to also track what is happening at subnationals, which is what you just brought up. And that is key, because we think of governance purely in Nigeria from the center because of a system that has been probably bushwhacked by the military. So we are all about top down. But what about the implementation level, ground zero of governance, which is, even now with the local government autonomy, it brings even another dimension to this conversation. How do we get the local government to be more on board on health? How do we see them? Yesterday, we were with Professor Patti at Transcorp, the Universal Health Coverage Summit with legislatures, the legislatures of the country. And these are part of the conversations that came up. Now, this issue of local government autonomy, how do we track, follow the money, and make sure that they are also performing, because they're actually more of the custodians of primary health care. So the money that comes from the statutory transfer of basic care provision fund is not a cure-all, it's catalytic. I know even big, by the time it's shared across the country, you probably don't have anything significant. But then the idea is a signature that we want to get primary health care right. States, local government, what are you doing with primary health care? We need to ask those questions.
That's a very important question, and we hope that we can get answers from the subnationals. But I'd like to get to Dr. Ariogbe, and I'd like him to react to a comment he made earlier about why medical personnel are leaving the country. You mentioned that it's for the sake of learning and interaction with experts, but we know from records and what we see outside the country that Nigerians do not necessarily go outside Nigeria to get education, medical education. They would rather prefer to get it right here in Nigeria and then eventually leave the country. So it means that there's so much here in terms of educational resources and skills. Okay, our medical schools are working and functional. Our professors right there are still doing the needful, and we see that even when they leave, they are able to do very well. So I want you to explain what you mean by learning and interaction with experts has been the reason, because there will be no need getting the education right here if we do not have the education that is required to do very well as medical personnel.
Yes, of course. Thanks. I will try to explain that. So I schooled in the College of Medicine, University of Lagos, Idiaraba. And I can tell you that you have some of the best professors, best teachers in the country. And these were people who, a lot of them trained in Nigeria, but some also trained overseas. And we learned a lot from them. And across the nation, we have very good teachers right now who are trying to make effort to ensure that medical students, nursing students, pharmacists, allied health professionals that they are well trained. You are right in that. In terms of the basic training, we do have the experts there. Even when it comes to postgraduate training, also we do have very good consultants and professors, who taught us. But when it comes to you as a doctor, you've now qualified as a doctor, and you want to now specialize in a particular area, be it obs and gynae, ophthalmology, orthopedics, you name it. There is a bottleneck in terms of how you get into the system. And there are a lot of barriers you need to overcome for you to get into that system. So that is where most of the problems actually lie, where people will now start looking overseas to say, hey, listen, I'm not getting younger. I'm determined to become an orthopod or a gynecologist, and the opportunities are not here in Nigeria, or the opportunities may be there, but the facilities are not really up to standard. There is a difference between you practicing in Nigeria and doing what you can with what you have, which is okay, compared to where you go to a country. It could be the United States, it could be in Canada, it could be South Africa, it could be anywhere in the world, where they can do that same procedure using modern technology, using modern methods to ensure that, the outcome is much better than what you can get, say, in Nigeria. And I have examples of this, so I'm not talking based on hearsay. My mom passed away in Nigeria because of poor negligence from a medical doctor. She was diabetic, but the care she received was appalling. If that doctor was here overseas, he would probably be in jail by now. I'm a doctor, and I know what I have to do to ensure that the patient survives here in this country. You have to make sure that everything is done. And because you have everything that you need, you have the specialists, you have the facilities, communication, government support, everything is here. I'm not saying it's perfect, but they have it here available. But back in Nigeria, it's not really up to that standard. I'm not trying to belittle what is being done in Nigeria. People are using what they have to sort of, achieve goals, which, it's not very easy. Lack of funding, lack of sometimes government support and all that. And some of the challenges we mentioned already, they are also there. But they are trying to do that. But we cannot compare what we get here to what happens in Nigeria. Yes, we have the experts. We see some of them come overseas also for training. Some of them come overseas also, to do rotations in various specialty and all that. And they go back to Nigeria to use those skills in Nigeria also. So the medical school training in Nigeria is top notch. I really value my training in Medilag a lot. And I also value the experience that I have right now in terms of working in 2 different countries, in South Africa and also in Canada, and seeing the impact that's made in my life, and also the colleagues that I also interact with. We all know and we all agree that, yes, our medical education is good, although there are some cracks right now in the world from what we hear in terms of the training and all that, but it is good. It's a good place to start with. When it comes to postgraduate training, it's also good. And if you want to go overseas, you can also go overseas. I'm not saying doctors overseas are better than the ones in Nigeria in a particular specialty. I'm saying that there are different levels of exposure that they do have. And most of the time, those overseas, they have a higher level of exposure. And that makes them sort of better, than, say, the Nigerian colleagues. Thank you. I'll stop there for now.
All right, Dr. Itua, thank you. I really want to thank you very much for the points that you have raised, but also to say that indeed the private medical practitioners in Nigeria are doing quite well now, if you ask me. Many of them now perform very complex medical surgeries, that when done here, and the patients, get aftercare at reasonable and affordable cost. I could go on and mention, quite a number of hospitals, even the public hospitals, the National Hospital here in Abuja, for instance, now has capacity to deal with, very complex medical surgeries. But the issue is, what kind of framework would you, recommend, to be able to enable, our young medical doctors to remain at home and access some of these facilities, in these private hospitals rather than jumping abroad to seek for greener pastures in Canada or wherever?
That's a tough one, because each individual determines, what he or she wants to do. Migration is a human right. They have a right to move if they want to. But it's of, how do we retain doctors? How do we make sure that they stay back in the country and they do not, go overseas? You just stated it right now. It has to do with the facilities that we do have in Nigeria. If those facilities are up to date, up to standard, and if they're accessible, people will stay back in Nigeria. There's no place like home, I'll say. There's no place like home. But you're talking about private hospitals. So that is really like a top 1%, all right, that we have access to private hospitals that can afford it. It's not everybody. It's not the market woman on the street. It's not the shoemaker somewhere that we afford, that can go to those hospitals to get care. It's not possible because they cannot afford it. So, and that's the difference between, say, country like US, Canada, or UK, or Nigeria, is that because we have, and we don't pay for healthcare, so to speak. You can break your bone, you can break your back right now, and you have the best facility. They'll spend up to on you, and you will not pay a single cent from it. The government covers your health care, particularly in Canada, and all the provinces. So there is our universal health insurance that we have here in Canada. But in Nigeria, I know they're trying to develop that right now. That is not really available. So if you want to talk about retaining young minds, which I think is a good idea, you have to look at some of the diaspora doctors, people like us overseas, and bring them over to Nigeria, and how we can repatriate the skills that we have to the young ones in Nigeria, so that by the time they graduate, and also by the time they're already doing their residency, and they already have the experience of those people who have worked overseas right there in Nigeria, then the tendency will probably be for them to stay back, because there's this pipeline from the diaspora to Nigeria that repatriates skills back to Nigeria and retain our work in Nigeria. I'm talking about not just the doctors, but the nurses, the pharmacists, as well as the allied healthcare professionals. Thank you.
Ibiogbe, we are asking you to come home. Don't wait for us to come pick you. We hope that you take the next flight back to Nigeria and, of course, do some of the things that you're talking about. But let's get to Professor Audu now, the president of the Nigerian Medical Association. You heard Dr. Ibiogbe talk about his mother passing on as a result of negligence on the part of medical personnel. That's also another major issue in our health sector, because even when you're able to access healthcare, sometimes the medical practitioner or the doctor or whoever, should attend to you doesn't do the needful. It's a challenge. And then you heard, Michael Nyachi talk about the fact that there are issues even amongst the professional groups, and is causing, if you like, problems in the delivery of healthcare. Say a nurse would say, oh, well, this is supposed to be my duty, or that's not my duty, and decides to walk away, or a doctor should have done that, or this and all of that. So speak around these issues as being, also a challenge in the health sector and, increasing mortality rate.
Thank you. Let me start with medical negligence. Medical negligence is an issue that occurs all over the world, and Nigeria has its own shares. The Medical and Dental Council of Nigeria regulates medical practitioners in this country. And any issue of medical negligence is directed to the Medical and Dental Council. It has an investigative panel as well as a tribunal. And it has the status of a high court and can deliver judgment on, indeed, if there is medical negligence. Now, this happens in every country all over the world. Like I said, in Nigeria, we have our own share of that. But if we look at the regulation of practitioners, what about the regulation of facilities? Let me take an example of the case Dr. Itwas spoke about. And I really am sorry that happened to your mother. If you look probably at that health facility, did they have enough infrastructure, equipment, and even good storage of patients to handle that case? If they are on the side of the facility, there is no regulatory body in this country that enforces that. I'll give you another very simple example. I'm a gynecologist interested in gynecological cancers. I screen a patient, for instance, for cervical cancer, and I suspect that it's more than just a high-grade squamous interstitial lesion, that it might be an early disease. I say, okay, for me to be able to make that diagnosis effectively and give that patient the right kind of treatment, which will be completely a different treatment if it's an early disease from if it's a pre-invasive lesion. And for instance, I need an MRI to make that diagnosis. And there's no functional MRI in my facility. For example, where I practice in Azure, because I know there isn't one there. The nearest place would probably be Medu. That is in recent times. For some time back, I might have had to refer such a patient to Ibadan. The patient would go there is a waiting time to get on the list to get that investigation done. But as we very well know, most patients will fall under the category of those who cannot even afford to travel up to get that care. So what do I do? Probably say, okay, the best I can do is to say it's a pre-cancerous disease or an early disease and just treat within what is available to me. But 6 months down the line, she comes with a recurrent fulminating disease that shows that my diagnosis was not correct because I didn't have an MRI diagnosis, nor was my patient ready to travel elsewhere to get that. So what were my options? To refuse to treat that patient because I do not have an MRI, to do what I can do and end up with this kind of scenario. And if I end up with that kind of scenario and the patient's relation take me before Medical and Dental Council investigative panel, they'll probably find me guilty because I needed to do additional investigations that I didn't do, but they cannot find my facility guilty for employing me and giving me the role of a gynecological oncologist without providing me with the facilities to function effectively. So you see, there is a major gap here, and we need to standardize, not just practice by practitioners. We also need to standardize the minimal requirement at each level of care to say this is a primary health care facility and define what a primary health care facility, the minimum it can do, the minimum infrastructure it must have, the minimum manpower help it must have, and the minimum requirements of what it must have for preventive care as well as for curative care. It's not just enough to have that on paper. You must also ensure that there is a sustainable way to ensure that they practice those standards. And you must have that for secondary care, you must have that for tertiary care. And what we end up with...
Professor Thank you. Thank you. Let me quickly just, draw your attention back to the issues that your response to the issue that Dr. Itwa raised about medical negligence. And really, that it happens all over the world shouldn't be an excuse for us. I mean, it's high time we became an exception in that area. I think what he tried to do is to use his mother's case, to point to the distrust in the system by the people. The question should be, how can we build public trust in a medical system, in a healthcare system?
Yes, I only illustrated that. I first brought it out as a dynamic that happens all over the world so that people understand that it's not peculiar to Nigeria. Then I try to illustrate to you what the gaps are, and the point is, how do we now bridge this gap? I thought that is the essence of this discussion. We're not shying away from the responsibility. The point I'm trying to emphasize is its existence and how to mitigate the problem. So unless we identify that it exists and that existence is not peculiar to any country, then we can now address what are the gaps in our system that makes it happen, and how do we bridge such a gap? So the essence of by bringing that out clearly is to show where gaps exist and to proffer solutions on how to address those gaps. And the point I'm making is that these gaps reside both with practitioners as well as with facilities in which these practitioners practice. So we need to bridge knowledge gap, practice gap, as well as standardized provision of what is the minimum standard that every registered facility must have. The registered practitioners are under a well-recognized, highly reputable regulatory body, which is the Medical and Dental Council of Nigeria. But the facilities don't have such regulation. That is a gap that needs to be bridged.
So many gaps to be bridged in the health sector, and that's why we're having this conversation. We'll continue the conversation. Let's take a quick break. We'll be right back. Stay with us.
The federal government of Nigeria.
All right, welcome back. It's still Good Morning Nigeria, live on the network service of the NTA, and our guests are still very much with us. Would like to get to Michael Nanchi now, and so far our guests have mentioned the issues, or if you like, the problems in the health sector. But there are some recommendations as regards the way we could come out of all of this. Some have said the focus on preventive care, health education, and early intervention could reduce the burden on medical facilities and, if you like, medical personnel. Say, for example, education about sanitation, nutrition, disease prevention, and all of that. Speak to us about how we can go about this, just so we can address some of these issues.
I want to thank you so much for this very important opportunity, but let me remind you of something I have observed. I made my comments telling you about lack of teamwork, poor conditions of service, underemployment of nurses. I'm surprised you never made any comment along that line. And you are talking on a very important topic, bridging the gaps in the health sector, Nigerian health sector. And you cannot look at teamwork. You cannot look at conditions of service. You are digressing to the area where certainly you cannot achieve anything without the nurses and midwives. I'm very, very surprised. So I want you to, yes, in as much as you want me to make an input in those critical areas, I want you to look at underemployment and the conditions of service of nurses. Because this seems to be an opportunity to say this, not just maybe hearing from me and not addressing such issues.
Mr. Nnachi, if you were listening, if we are listening, every of our guests, addressed questions, and some of the issues we've raised, they were mentioned. So we do not have to, bother you, to give us a wider response. We know that these are factors. Condition of service is a factor, and that is why people. And I was going to say that, look, people are running away because of what they intend to get, because of the pay. So if you address the issue of the working conditions, of course, especially within the health sector, that would be a critical way of addressing the problem. So from your perspective, what do you think the government can do? What will be the right what will be the right strategy to ensure that medical practitioners, especially nurses, are better catered for?
Because of the compassion I have for the Nigerian health sector to work, I am seeking to have a good teamwork among the healthcare professionals. That will give us opportunity to actually utilize what we have to offer the best for the patient and the all healthcare consumers. A lot of things have been politicized when it comes to the nurses. And they not until the Nigerian nurses are made were down their queue for 2-3 days. That is the only time the government may respond to their needs. Over this period, our submission is before the government, but up till now, nothing has been done. We've been silent because we know that engagement in strike will definitely lead to loss of life. We have been so passionate about that because that loss of life, you will never know the person that is involved. And no matter who that is involved, it's a relation, it's a Nigerian. Therefore, that consideration has always been taken for granted, and everything about the nurses has so marginalized.
If you listen, like my colleague already told you, if you listen to other guests, they talk about medical personnel in general. Not just nurses are affected by this, condition of service. Of course, if you want to speak with a medical lab technician, for example, they would also speak around these issues. The doctors have the same issues. Pharmacists will tell you the same thing. So it is around every personnel around the health sector, or rather in the health sector. So that point has been made. We're looking out for ways, to solve some of these problems. And so if you think that or you can recommend a way out of this, we'd like you to speak around it. And then don't also forget that we're not just talking about this because of medical personnel alone. We're talking about it for the sake of Nigerians in general who are affected by the weak health system that we have in the country. So that's what we're speaking around. So don't think that your point hasn't been made. So I would still want to ask you my question, and I'd like you to respond, because you're the president of the National Association of Nigerian Nurses and Midwives, and when it comes to education, getting the people enlightened about preventive care and all of that, it's mostly in your purview. So I want you to speak around it. How can this be a way out? Just so that, of course, the Japa phenomenon is with us. We have nurses living the country every day, doctors living every day. So how can we look at other issues just so that we don't overburden the health system that is weak?
It's all right. Thank you so much. We all collectively agree that Nigeria is hard tossing. What am I saying? Insecurity here and there. In health sector, there are areas we call difficult to reach areas. The nurses go to the extent of getting to those areas. Sometimes become victim of kidnapping. Sometimes they are killed. A lot of things happen. Improving the security situation will equally help. Then, like I have said about conditions of service, providing what is required for the nurses to work anywhere. Any trained nurse is willing and ready to work anywhere in the country. No matter what, they are ready to offer their life. And that is the profession they have chosen to serve humanity. So, teamwork is very, very important, because there is no healthcare professional that is not important. And I know very well that no one professional group can do it right. And that's why I say that nobody can clap with one hand. You need one another to work. Therefore, the issue about conditions of service need to be addressed, identification of these problems and harmonizing them will help us to move forward. And of course, I have said here, the government is trying so well by providing equipment. But some of these equipment are underutilized. Some of them, maintenance is a challenge. There are some hospitals that you go, you will identify highly expensive machine, and you discover that that machine has never been used for once. And some of them will remain there and then become not only inserviceable, but they cannot be put into the use for the purpose for which they were secured. Meanwhile, they are all expensive machines.
Yes.
Okay.
So the government should be sensitive about what is happening in the Nigeria health sector. Nobody likes to be living to other countries because of anything. Like I said, the parents of these people living, where are they? In Nigeria. And there is no average Nigerian worker that can afford health sector outside Nigeria. If it's here in Nigeria, only the politicians can afford to fly them, their families anywhere. Therefore, if we cannot address the issue of bridging the gap, which is critical in this discussion, then we are not ready to provide the solution. For me, the nurses, Nigerian nurses and midwives are ready to work anywhere. They are ready to collaborate. Many are not employed. They need to be employed.
Thank you very much,
And
Michael
because they are not
Nachi. Your point has been made. Your point has been made. Thank you. Because of time, we'll have to move to our other guest. Of course, my colleague here has a question, or I'm sure an observation about what you have said, and she's going to let you know that shortly. But I'd like Dr. Iriogwe to speak around the political will, which Dr. Ohanyido spoke about. And then, like Michael is trying to mention, we have, people seeking medical tourism, of course, mostly by the political class. How can we solve this problem? Would you think that maybe legislation such that, if the political class get to seek medical attention in the country, that would, propel them or, bring about the political will, to get the health sector right in the country? Because at the moment, statistics puts it at 664 billion naira, on medical tourism, leaving the country at the moment. So speak around that, and of course, I'm sure Michael would get the response from Claire.
Yeah, thank you. So I don't think, that's a good option in terms of the political will. So the politicians, they should stay back in Nigeria and use the facilities, that we have, that everybody uses, that's one option. But I don't think that will actually solve the problem in terms of developing the healthcare system in Nigeria. We really have to look at it from a very holistic point of view. Yes, you're right. The optics will not be too good for you to see somebody fly overseas because the person holds political office. That's what obtains right now in the country. We all know that. And Mr. Michael Nachi made mention of that. That's really politicians sometimes who can afford care overseas. Even those who are rich also, they do try to do that. So we have to look inwards. We have to look inwards to develop the country. I've never seen even the president of South Africa travel overseas for treatment. It doesn't happen because the capacity, that they have in South Africa is able to look after the healthcare of its citizens from birth to death, so to speak. So political will is important, but political will has to be translated into policies, into laws, into legislation. That is where the political will is. It's not do not travel overseas. That is very short-term measure that will not hold water. We've been doing this for many, many years. I'm not an old person, but that policy has not worked. We have to look at the facilities we have in the country and look at how can we develop them. What sort of equipment do we need? The primary healthcare system, like my colleague said, how do we develop the primary healthcare system? That is the bedrock of any healthcare system in the world. In Canada, primary healthcare is king. I'm not joking. The government looks at primary healthcare quite a lot to make sure that, it is very stable and is steady. We have to look at the primary healthcare system. The primary healthcare system works. Then tertiary healthcare system, you don't have a lot of patients going to tertiary healthcare system to seek care when primary healthcare system is actually quite functional. Look at retaining workers also, like what Mr. Michael is talking about. What are their needs? What sort of gratuities do they have? What sort of policies in place, safety mechanism in place that they have, hazard allowance. So there are a whole lot of factors, that the government really needs to do to retain workers in Nigeria. My colleague here talked about the healthcare facility. Yes, look after the doctor. What about the healthcare facility itself? What sort of equipment do they have? Do they have the right equipment? Are they supposed to do this particular surgery in this particular area? Are they licensed to do that or not? Those regulations, they need to be in place, but we have to take it one step at a time.
I agree with you, Dr. Itwa. I agree with you, one step at a time. And indeed, Mr. Nnachi talked about or raised two issues. Please, I would like you to quickly, if you can, say in 2 minutes, to just share your experience or the experience in Canada with us on the issue of collaboration, between all the different unions involved in healthcare delivery. How do they synergize, for effective healthcare delivery? And then what are the metrics in determining the condition of service?
Okay, so very quickly, there is collaboration. There's also politics. I'll tell you, anywhere in the world, doctors, nurses, you name it. But everybody has a common goal. We have to take care of the patient-centered, and politics falls aside completely. We collaborate a lot with our allied healthcare services. Without them, we cannot work. I'm serious. You can't draw blood. You can't. The nurses, they take care of patients. So it's so intertwined that we see ourselves as one right now, and we collaborate. We have meetings together. We have seminars together. We share ideas together. We talk together quite a lot, both informally and formally also, so that we are all on the same page when it comes to healthcare delivery system. If we do not do that, the healthcare system will collapse. There is really no, I'm the boss, you are below me. That sort of attitude does not work here overseas. Everybody is on the same level. You respect them for who they are. They respect you for who you are. And sometimes nurses can actually correct you if you're making a mistake. It's not pride. You have to accept it and say, oh, thank you so much for that. And, you do what you have to do. That's how it works here. So the collaboration is quite important in this place. And I hope that, that we look at it that way in Nigeria also, to see that sort of collaboration, that it is all for one and one for all, that we're all together in this to deliver a proper healthcare system to the patient and to make Nigeria, a better place. I forgot the second part of your question.
What about the pay?
Pay and condition of service.
So they have standards. I don't have this on top of my head right now. They have standard rates, hourly rate for nurses, what they get paid. Doctors also, we don't get paid hourly. Well, it depends. So there are two systems. So there are some people who are on salaries. There are some who are just private. So private means you bill the government for a patient that you see based on the disease condition. So some people opt for that. I'm in that particular section. Others opt for a salary system. The nurses, most of them are on per hourly rates. The rates are very, very good. That's why they come overseas. And LPN, registered nurse, my goodness, they are well taken care of, and they can move anywhere. They can migrate anywhere within the country because they are in need, So when people from Nigeria, they see that, I don't blame them sometimes, that you have such liberty. You can have a house, have a home, that is worth $600,000, $500,000. You have a car, you have access to so many things. You'll be attracted to, you want to come overseas. So the standard of your pay, your benefits, it is set. It is non-negotiable. It's like a law. No government official, anybody can come in and try and change that. You do that, there will be war. So the government takes care of all that. Thank you.
Why a lot of people are in a hurry, to move to those other countries, and we hope that we can begin to see all of that being replicated right here in Nigeria, so people can stay and be proud of their jobs right here in the country. So I'd like you to respond to some of the comments made so far, and then your recommendation in all of this. How can we bridge this gap and solve some of the problems in the health sector, Dr. Ohaniyido?
Okay, so let me start by saying that, a lot of the points they've made are germane, and I'm very happy that we have started this conversation. It's something that we need to do more. as a country, so that we'll have a focus on the key things that we need to leverage on to change the health system. But critical among this is the fact that the current minister, the coordinating minister of health and social welfare, Professor Patti, has a 4-point agenda. And this 4-point agenda are around 4 pillars, and those pillars are around governance, infrastructure, finance, and workforce. So you can see that a lot of things we've talked about here come there. Let me take the issue of finances. So I'll just, I think those are okay. Health finance is very critical. That every Nigerian should get health commensurate to the naira they put in health. But the biggest problem we have so far in Nigeria is the fact that most people pay from out of pocket. And once you do out of pocket, the risk for you is that you can throw you into poverty. Somebody who, for some circumstances, the family head gets ill, and that's the breadwinner of the home, and they don't have health insurance, for example, and they end up taking the guy to the hospital, or the man dies, for example, or the woman dies, the breadwinner, whichever it is. That family can go into poverty. And those are drivers of even insecurity in our country. We have already multidimensional poverty. So one of the key things we need to do around the financing pillar is to make sure that health insurance works. So that even the woman on the street who is selling akara, she'll have some modicum of health insurance. Even if any member of her family is sick, can get even a premium that covers like even 20,000 naira. You know, so those things are that. Then the other side of the health workforce, how can we reimagine the system in such a way that, because health insurance already is tied to this, because if health insurance work, now we're talking about mandatory health insurance for everybody in Nigeria. If we're able to do that, we will unlock private sector performance within the system, and there'll be more money in the system for hospitals. And you will now see that hospitals will be more competitive. They'll offer you all sorts of services. We need to make it work. We need to make sure that health insurance works, especially at subnational levels.
I think, Dr. Francis, that's a very good place to say thank you.
Yes.
We need to make the health insurance work anyway.
All right. Thank you very much to all our guests. We hope that we find solution to some of these problems that we have mentioned. So I'd like to appreciate you, Dr. Francis Ohanyido, Director General, West African Institute of Public Health. Thank you for coming on Good Morning Nigeria.
Thank you very much. My pleasure.
Of course, we appreciate Professor Bala Mohammed Audu, the President, Nigerian Medical Association. Thank you so much for being our guest. Michael Nachi, President, National Association of Nigerian Nurses and Midwives. Thank you so much, and I'm sure the welfare of nurses and midwives will be looked at. Dr. Itwa Godson Iriogbe, President, Canadian Association of Nigerian Physicians and Dentists. We're looking forward to seeing you in the studio and seeing you, do something in our health sector in Nigeria very soon. Thank you very much for being our guest. All right.
All right, and that's it for Good Morning Nigeria for today, and indeed for the week. On behalf of all the Good Morning Nigeria crew, the wonderful men and women behind the scene, I'd like to thank you too for joining us. I am Claire Adilabo Abdul Razak, and God willing, we'll be back same time next week, Monday. Bye-bye.
And I'm Ian Ray John. Enjoy your weekend.